now?
Yes, doctor. I think recorded is okay, doctor.
So it is still breaking now? Is it still breaking now?
Yes, yes, doctor.
Okay, just a moment. Let me try. You guys just wait for a while. I try to use my phone. Moment. You guys hear me?
Yes,
Or
doctor,
is
we can
it
hear you.
breaking?
Still breaking, doctor,
It's breaking.
unfortunately. Now it's okay.
Breaking also.
Oh, now it's fine. Now it's okay, doctor.
We try, yeah? Is it break?
It's okay, doctor. We can.
Okay, so these questions, what are the drugs which to placenta commonly? So basically, all will pass through the placenta. It's either the passing through the placenta.
Doctor, I'm so sorry. I'm
So
so
what you
sorry.
need to
Again.
breaking. Wait, I really want to get this done. Student, can you hear me?
Doctor, so sorry, but it's still breaking.
Student, can you hear?
Cannot, doctor. Sorry, doctor. You're breaking again.
Can you?
Hello, doctor.
Can you hear me?
Uh, Now yes, but then just now it was breaking.
Can you hear me now?
Can, doctor, can.
Okay, so let's start again, yeah? Okay, what are the drugs which will not pass through the placenta commonly used in cesarean sections of dogs and cats? So actually, this is quite a standard protocol. Propofol, isoflurane, both drugs can pass the placenta. So you need to coordinate with the surgeon. The surgeon has to be quick. Okay, the surgeon has to be quick. All drugs can cause a detrimental effect to the fetuses. So, basic rule of thumbs, you want for cesarean section, you want to choose the drug which is short. You want to choose the drug that has a short duration of action or drug which has a specific antagonist available, meaning that once you inject and you have the antagonist to reverse it, okay? And then usually in the in this cesarean section patient, I mean, commonly we perform this in a dystocia patient. So they are basically very weak. We does not need full dose. We can reduce the dose, okay? We can reduce the dose 30 to 50, 60% or titrate to effect, okay? So try to minimize the usage of the drugs, okay? So, and propofol isoflurane protocol has a very good survival outcome, even though they're able to pass. So it need to coordinate between the anesthetist and the surgeon and the whole team. Okay? Can you guys get this?
Yes, doctor.
Okay, so one, you have to know all drug basically can pass the placenta barrier. Second, choose the short duration of actions of drugs or drugs that have the antagonist to reverse it. Third, you can reduce the dose of the calculated dose because usually these them are generally are very weak because straining to deliver for a long time, so you can reduce the dose. So this is probably we increased a survival outcome of the fetuses. Okay, for ovarian hysterectomy, can we cut the suspensory ligament instead of tearing it? What is the risk of doing that? Basically, this is a surgeon preference. Myself, my practice, I will cut the cat. I will cut the cat suspensory ligament. Okay. For dogs, I prefer to tear. Why? Because most of the time, it is the dog, you need to tear the suspensory ligament before you're able to exteriorize the ovaries, the ovarian bursa, and also the ovarian vessel. Okay. Again, it's also depend on the incision size. If the incision size is long and you're able to see, then you can cut the dog suspensory ligament. But usually the incision size does not allow you. I'm talking about dog, yeah. It does not allow you to fully exteriorize the suspensory ligament and cut it. So generally, you need to insert your finger into the abdominal cavity, feel for the suspensory ligament, and tear it, okay? And tear it. For cat, from my experience, it is easier to exteriorize the uterus even though it still have the intact suspensory ligament. Okay, that's why because I can see it, then I feel more comfortable to cut the cat suspensory ligament. However, this is basically the surgeon preference. So in our practical class, if we can have dog, you can make a standard small incision first and then try to identify or feel for your suspensory ligament and try to tear it, okay, with a lateral medial movement, okay? So we're going to demo and practice this during the OHE. So the answer is yes, we can cut, but it is surgeon preference and also your preference. And then what is the advantages and disadvantages of performing scrotal and pre-scrotal castration in dogs? Which one is preferred? Dogs. Okay, so cat is a scrotal incision. Dogs, I always perform pre-scrotal incisions. I never perform scrotal castration. Scrotal castration, I mean cut into the scrotum and remove the testicle from there. Okay, so when I think cutting into the scrotal will cause more bleedings. Okay. However, in these studies, you can check DVM 360 scrotal castration versus pre-scrotal castration. They found that scrotal castration has a better outcome. Okay. But again, like I say, this is really a surgeon preference. I basically just do what I was taught to me by my lectures. So I will stick to pre-scrotal, okay? If during you practice, if you feel that scrotal constriction is more easier for you to handling, so just go ahead, okay? But of course, every surgical procedures, you must explain to the owners what you're planning to do, okay, and possible complication. For transpelvic urethrostomy, is there any complication due to the removal of the symphyseal part? No, I do not experience the problem with the burring, probably 1 cm of the symphyseal part or bone. Okay, the only issues here is the stenosis of the stomy or the opening. Okay, so no issue with the removal of the symphysis, but of course you don't want to remove excessively. Okay, so this question, Mira, can you please check? I am not really understand the question, but if you can ask the student, so I can update later. When is the best time to use catheterization, and when do we use cystocentesis in removing urolith? I really do not understand this one. So when is the best time to use catheterization for what? Okay, and when do we use cystocentesis in removing urolith? We can never remove stone with cystocentesis. Cystocentesis basically two purposes of you perform cystocentesis. One is for taking urine for culture and antibiotic and sensitivity. That's secondly, because the exit of the urine, which is the urethra, is blocked, stenosed, narrowed. Um, that's and you want to prevent the bladder from getting bigger and lead to rupture, you perform the cystocentesis. So we never perform cystocentesis to remove urolith. Urolith must be, to remove urolith, you must perform a cystotomy. Okay, open up the bladder and remove the stone. Of course, from literature, you can find a lot more fancy procedures. In dogs, probably they have this scope and the basket to remove the stone, but in UVH setting, we always perform a cystotomy to remove the urolith. Okay, number 14. It is a must to conduct ultrasound if we could not palpate the retained testicle at the abdomen, inguinal site, or penis. Is there any possibility an animal is born with only one testicle? So this also is really based on a surgeon. So for me, it's always a yes. If I cannot palpate a retained testicle at the inguinal or the side of the penis, I would definitely order an ultrasound. Okay, why? Because I don't want to waste my time exploring the intra-abdominal cavity, hunting, looking for that retained testicle. Okay. Besides that, you will increase your GA time if you keep swimming inside the abdominal cavity, try to look for that testicle. So yes, one testicle is possible. That is why it's like if you cannot confirm, but actually I think most of the time a retained testicle, our radiologist able to ultrasound them. Okay, they're able to ultrasound them. So besides that, ultrasound also help to rule out neoplasm and also define whether this is left or right testicle. So during the surgery, you already know which side is left or right. So basically you can directly go to the site of the affected site. Okay, so why it is important to rule out neoplasm? Because if you have a undescended testis or retained testicle, it is 13.6 times more likely to develop into neoplasia. And also, undescended testis has higher risk of torsion. Okay, so all this, if you can identify before you going in, it really help you with your post-surgical and post-op planning. Okay, so again, the common is actually prescotal area, the inguinal region, and abdominal cavity. Okay, from these studies, so where are commonly find from these studies, from 243 40 cryptorchid dogs, commonly found is in the right inguinal regions in dogs, and cat is more balanced. They can find between left and right inguinal region. So that's why we need to ultrasound it. Okay, that's why we need to ultrasound it. Does doctor recommend a phallopexy in cases of paraphimosis? Depend on case-to-case basis. But what our local scenario is, most of the time when the owner bring in the cat, the extruded penis is too much damage to be safe. Okay, meaning that it's already ulcerated, it's already necrotized, it's already gangrene. Okay, that's why I would always, if based on that appearance and physical examination, that's why a penile amputation is always recommended. If it come in and just happen, you can try a conventional method, meaning that to shrink the swelling and try to push back the penis. If it happened again, yes, you can recommend a phallopexy. But however, this is a permanent procedure, meaning that you tag the penis to the prepuce, to the mucosa of the prepuce. So you can check these procedures in these papers. Phallopexy for treatment of paraphimosis in dog. However, you need to check what caused the paraphimosis. Okay, whether it's a new neurological, is a trauma, you have to define that. Okay, so basically you take off, this is the penis, you take off this part of the skin and you suture it to the mucosa of the prepuce. Okay, so it will permanently stay inside the prepuce. So why does hematuria occur after nephrectomy? Because you cut the ureter or you perform the cystotomy. So that's why you have the bleedings. Doctor mentioned that if perineal urethrostomy failed before we do prepubic urethrostomy, can do the transpelvic. Maybe I didn't catch it or I misheard, but is it compulsory to do the transpelvic one before PPU, or is either one? So basically it's based on the surgeon. If the surgeon has no experience or skill in performing transpelvic, then the patient has no other choice in go for PPU. Okay, so is it an option based on patient evaluations? Okay, it's just that if you're able to perform TPU, you probably has less cystitis and problem that going to arises because of very short urethra. Okay, so it is an option, and also based on the surgeon skills. Okay, okay, done. So everyone, can everyone clear with the questions and answer? Okay, if you still have questions, please, Mira, collect it. We for sure going to have our test one next week. Okay, it will be your MCQ, probably mix and match, or those questions that can be done. Are definitely no essay. Okay, I'm not sure about Dr. Ong. You can ask about her part, but my part would be MCQ or those kind of choices. Okay, so any questions? Please please pass to Dr. to Mira. Okay, and we can get an update to each other. Okay, thank you everyone.
Thank you, doctor.
Thank you, doctor.
Okay.
Thank you, Doctor.
Doctor.
Okay, thank you. Bye bye.